Well, I do hope some of you have watched the long interview with Dr. William Maki, but for those of you that found it a bit long, I've just taken a bit out of the bowels of the video. This was on fenbendazole and a very similar drug, mebendazole, in his role in cancer. And we talk about the way that it's based on very firm science, known biochemistry. We're just lacking the clinical trials because there's no money in it. And we also mention the small cell lung carcinoma, which is a totally deadly form of cancer normally, that Joe Tippins was, as far as we know, is still alive and well. If Mr. Tippins is watching, do let us know how you are now, sir. But let's watch this. We really need to get our act together on repurposed drugs, start saving lives, start getting rid of a lot of human pain, suffering and death. We need the research that answers our questions definitively. Let's hope we get it. Let's watch the clip.
Another antiparasitic, fenbendazole or mebendazole. Now, this is a different family of antiparasitics than ivermectin. Fenbendazole was actually interestingly discovered by a terminal cancer patient from Oklahoma, Joe Tippins. And Joe Tippins had stage 4 small cell lung cancer, which is one of the most aggressive cancers known. And he had stage 4 small cell lung cancer diagnosis, terminal diagnosis, and I believe he was put on a trial of Keytruda at the time. And
is that a regular cancer drug?
It is a regular cancer drug, yes. And sort of what they call an immune checkpoint inhibitor.
Yeah.
And so he was put on Keytruda, and he tells the story later on that everybody on that trial died. He was the only one who survived. And he tells the story of how he had a friend who was a veterinarian who said, look, there's this parasitic drug, this dog dewormer called fenbendazole. It's been accidentally found to have anti-cancer properties in mice. It's cheap. It's safe to take. Why don't you try it? And the story goes that, he tried this dog dewormer, dog medicine, I guess you could say. And he cured his stage 4 small cell lung cancer, which is completely unheard of. I think he was given a survival of less than 1%, sort of a 5-year survival of less than 1%. And he's still here to this day. 7 years later, he's cancer free with a stage 4 small cell cancer diagnosis. And so at the time, he would actually go on news shows and talk about his experience of trying fenbendazole, which was not FDA approved for use in humans, and how it cured his or he believed that it cured his stage 4 cancer. And then, I look into that research, that body of research. See, again, there's a ton of preclinical research on fenbendazole, and there's now been cases published by Stanford University Medical Center of 3 patients who cured their stage 4 cancer with fenbendazole. And the Stanford group looked into it, analyzed it, monitored these patients. These patients had all failed 3 or 4 lines of chemotherapy. They were terminal. They took fenbendazole, and they are now cancer-free. And the Stanford group published this. Now, the Stanford group itself, the researchers were not allowed to recommend that drug, fenbendazole, because it's not FDA approved. But they were at least, this is what I love about science, is that they saw something fascinating. They saw something that they thought other doctors and scientists should know about, and they published it. And they published this case series. You had actually talked about this. You had talked about this paper from 2021. This series of 3 people who had cured their cancer with fenbendazole. And so there is an FDA-approved version of fenbendazole called mebendazole. It's structurally almost identical. There's 1 atom difference between fenbendazole and mebendazole. Mebendazole has been approved by the FDA as an antiparasitic drug for use in children and adults. And so it has an incredible safety profile, very safe to use. And mebendazole actually has a dozen clinical trials in which it's being looked at as a cancer agent, as a repurposed drug for cancer. And so I think because of its status as an FDA-approved drug, there was much more willingness in the oncology community to do trials with it. And so there are trials in adults looking at colon cancer and various prostate cancer, and there's also trials in children looking at brain cancers with mebendazole. And again, this is an antiparasitic drug that has a dozen mechanisms of action. One of the fascinating mechanisms of action in cancer is that it blocks glucose transporters on cancer cells. And so it sort of starves the cancer cell from being able to use glucose as a fuel source.
Specifically in cancer cells and not on normal cells.
Yeah, exactly.
Glucose transporting in cancer cell. That's amazing. So there must be something biochemically different about the glucose transporter in cancer cells compared to ordinary cells that it's able to specifically target.
Exactly. And what's fascinating about these repurposed drugs is they are very specific to cancer cells. They are able to somehow identify a cancer cell from a normal cell. And this has been studied in ivermectin as well. Is ivermectin is actually able to identify lymphoma cells and act on them. And it's able to also identify normal cells, and it doesn't have that same effect on the normal cells.
It's what we call a magic bullet.
It is absolutely fascinating.
Yeah.
And I encourage anyone look into the preclinical research. It is absolutely fascinating. And
the mechanisms that we're talking about here, that you're talking about, are based on known biochemical pathways. This is not something new. This is understood biochemistry, and these drugs interfere in a particular biochemical mechanism in a known biochemical way. This is not speculation. I mean, biochemistry is basically a hard science. I mean, medicine's a bit soft around the edges, but biochemistry is a hard science. It's bench chemistry, and you can't really argue with that. And the fact that it's got multiple mechanisms of action on multiple biochemical pathways, and that's true for ivermectin and the mebendazole-fenbendazole group. It's just absolutely incredible that these natural molecules seem to have these multiple modalities of action, and yet we're staring the gift horse in the mouth.
Exactly, and the research is very, very solid. The research on the mechanisms, the preclinical research, is very solid. This is not one or two papers. This has been, replicated. This is hundreds of papers for these antiparasitic drugs. So this is not, this is not a conspiracy theory. This is not fringe medicine.
Hard,
this is actually,
hard science. It's as hard as it gets.
Absolutely. This is hard science, and I love, I'm always fascinated by preclinical research because that is what we stand on. That is what the rest of medicine stands on is the preclinical research. That's what we rely on as physicians.
And that's what gives us the plausible mechanisms of action, because if you can't give a plausible mechanism of action, well, you're not fulfilling an essential Bradford Hill criteria apart from anything else. But if you can say, well, this is the way it's working, then that's what takes you into science away from mumbo jumbo. Because
Absolutely.
we've got existing science, and this pharmacodynamic effect, the way this drug is working, is dovetailing with what we already know, with multiple points of consistency with what is already known.
Exactly, and so I found myself in a situation where I was writing articles on Substack. I was writing articles about turbo cancer, potential mechanisms. We talked about this brand new pathophysiology of turbo cancers, and so. I have a paper that I co-authored on the IgG4 shift that could be one of the potential causes of turbo cancer, where we see someone who's had, let's say, multiple vaccines. They end up with an immune system shift where they start producing different types of antibodies, and instead of producing IgG1 and 3, they start producing IgG4. Which is an antibody that creates tolerance to something like the spike protein, but it also starts to tolerate cancer. And so I've been involved in some of this research in trying to figure out the mechanisms, but now I'm shifting towards treatment, and I'm shifting towards looking at, well, can we help patients with turbo cancer? How can we help them? Yeah. And certainly, I encourage everyone to pursue all the options in mainstream oncology, pursue all the options, whether it's chemotherapy, radiation therapy, immunotherapy, you have to pursue all those options. You have to have those discussions with your oncologist, but what else can you do? What if you're out of options? What other options are there? And I think this area of repurposed drugs, is something that we can try as clinicians, something that we can look into, advise patients on. And a lot of patients themselves are, they look at some of these repurposed drugs, and they start taking them. They start taking them themselves. So as I was writing about ivermectin and fenbendazole and mebendazole in cancer, I had patients who actually started taking them, and then they would come back to me 6 months later and say, Dr. Maki's, I read your articles and I took these on my own. There was no patient-doctor relationship or anything like that. They took them on their own, and they come back to me and they say, my cancers are shrinking. My oncologist is shocked. My oncologist told me I shouldn't be alive anymore, and yet I'm here. My cancer's stable. And so I kept getting story after story, and one or two stories you say, that's fantastic. I'm really happy for you. That's really terrific. But when you get a dozen or 24 stories like that, and that's what happened to me, is I started having so many patients coming back to me that I thought, there's something here where I could actually be helping patients with. I could be helping them with ivermectin. I could tell them about the potential side effects. I could guide them in dosing, for example. How do you dose these things, right? How do you find the appropriate dose for the appropriate condition? And so this is what I've been working on for the last 2 years. I did start a cancer clinic or sort of a cancer coaching or health coaching program with repurposed drugs, where I have cancer clients that come to me. We discuss the research, we look at the research, and we talk about repurposed drugs and what repurposed drugs they might use and want to try themselves. And so this is where I've been trying to go from just identifying the problem, saying, look, we've got this explosion of cancers, these turbo cancers, aggressive cancers, to actually helping patients and give them some options that they can use. And I've had some fascinating results. I've had a number of stage 4 pancreatic cancer patients who've been now declared cancer-free, cholangiocarcinoma patients, ovarian cancer patients whose tumors are shrinking, even though they failed multiple lines of chemotherapy. And
these are cancers that were absolute death sentences.
Exactly. And another feature I wanted to just mention is that these repurposed drugs, when you look at the preclinical research, they have synergy with chemotherapy. They have synergy with immunotherapy and even radiation therapy in some cases. And
I was amazed at the radiotherapy one, that you can actually sensitize a cell to radio-induced cell death. Is just incredible. It's just brilliant. It's
fascinating, because when you look at some of these mechanisms, some of them are known and some of them are still unknown. And
yes,
and you see all these biochemical pathways that ivermectin acts on, and all these pathways where it changes the expression of certain proteins, and then suddenly you stimulate apoptosis of the cancer cell.
The cell just goes pop and dies.
Exactly, the programmed cell death. And so a lot of these pathways that ivermectin, fenbendazole, mebendazole act on are pro-apoptotic pathways, where you're bringing that cancer cell towards this programmed cell death. And you're also, this idea of being able to remove drug resistance, a cancer cell that has developed drug resistance, to me is absolutely fascinating.
Yeah, how can you possibly reverse that? It's wonderful, but it's biochemistry well beyond my level of understanding, that's for sure.
It really is. It's pure biochemistry, and it's sometimes even I have a hard time understanding some of these pathways, but
I certainly do. Yeah.
But it really, the fact that it can affect expression of certain proteins and so
Amazing.
on, it's incredible. Yeah. And so I think repurposed drugs. I think there's a big future in repurposed drugs, and I think repurposed drugs can give patients hope in situations that are very dire and in the past would be considered hopeless.
We're dealing with drugs that are very safe, very limited side effect profile, can nearly always be given with all the regular, what you might call standard cancer treatments.
Exactly.
And for people who've exhausted the standard cancer treatments, stage 4 pancreatic cancer, for example, why not? Why not try something that's not going to do you any harm? You know, if you want to change the brand of whiskey that you drink in the last days of your life, then fine, try it. You know, but something like this that is potentially can potentially improve the condition is just incredible. And I am optimistic again in the States that the right to try is going to be reintroduced. That people who are terminal can basically try whatever they want, and I agree with that. One of the things I always used to teach my students was in acute care, sometimes patients are going to die, and you always have to be in a position where you can walk into the relatives, you can tell them about this tragic death, and you can say, we tried absolutely everything at our disposal. Now, that's not always true, tragically, but we should always work to that situation. We tried absolutely everything we've got in 2025, nothing else we could have done. And so many people are dying now, and that cannot be said.
You're absolutely right.
I'm trying not to get cross now, but it's just not acceptable.